So I'm Patrizia Inácio, BioNews service correspondent for Friedrich Taxi News. Dr. Lynch, thank you for being part of Friedrich Taxi News official coverage of the International Taxi Research Conference here in Pisa and to agreeing to being filmed and recorded for this interview. So our first question is, the ongoing phase 2 MOXIE trials, clearly of great interest to the FA community, has results could lead to Omavolex alone becoming a first approved treatment for this progressive disease. So of the different OMAV doses tested, results show that the 80 and 160 milligram doses were optimal in terms of the drug's efficacy and pharmacodynamics parameters. Can you please briefly tell us why the higher concentration, 300 milligrams, was not seen as optimal? Did it become toxic and cause serious side effects, or was the drug not effective at doses lower than 80 milligrams per day?
Okay. The dose selection was reflected the in vitro concentrations in which omavaloxolone is effective in vitro. Thus, there is a fall-off at higher doses in vitro, so it's not surprising that the top dose was not as effective. There were no increased adverse events, so it was not a matter of toxicity, but truly lack of benefit. Thus, the 80 and 160 milligram doses will be combined in the upcoming study to a dose of 150.
Results were assessed taking into account the modified Friedreich's Ataxia Rating Scale, mFARS. Which parameters are actually assessed with the scale, and why is the significance of, say, a 1-point decrease?
The modified FARS exam is a quantified neurological exam, very similar to what you'd get at your neurologist's office. It simply provides a way to measure disease progression over time. The average FA patient progresses about 2 points per year, depending on where they are in the disease and the severity of their disease. So 1 point of progression is about the amount of time that a person would typically progress in 1 to 2 years.
Results from Part 1 show that omavaloxolone significantly improved neural function in FA patients, with an improvement in mFARS of 3.8 compared to baseline at the 160 milligrams dose. Was this mFARS improvement clinically meaningful?
In this duration study, clinical meaning is very hard to determine. If this were maintained for an extended period of time, perhaps a year or something like that, and were of the same magnitude, it would be considered clinically significant, most likely.
The overall 3.8 point improvement over baseline in these patients dropped to a 3.3 improvement compared to those given placebo. Was this seen as a significant drop, and how clinically relevant is a 3-point mFARS improvement in FA patients?
So with the fall compared to placebo is expected in a short-term study. You have placebo effect in Friedreich ataxia studies, and you really should. Otherwise, you worry about how well you're doing the study. A 3-point increase is quite significant. That would be equivalent to what people would typically progress over the course really of a couple years. So that much improvement is quite an improvement.
What were the most common adverse effects reported in treated patients in Part 1?
In Part 1, there was a difference between placebo and drug in the number of pharyngeal infections and upper respiratory infections. The numbers are small, particularly in the placebo group. Whether this is meaningful is not really clear. Apart from this, there were really almost no major adverse events attributed to drug. It was a very clean drug all over.
Are there lingering concerns with the lesser benefits seen in treated patients with the muscular foot deformities known as pes cavus? We mean the improvements at optimal dose were 6 points over baseline and 4.4 compared to placebo when pes cavus patients were removed from trial data analysis. Are these findings possibly pointing to omavaloxolone being a better treatment for FA patients in early disease stages?
Good question. The meaning of the relatively greater improvement in people without pes cavus is unclear. It could represent to some degree the difficulty in performing the test and thus noisier data. It could represent some sort of a selection as to what stage of disease people were at, because pes cavus is a largely developmental phenomenon. It also could represent the amount of their disease that can respond in a short time scale to any agent. So I don't think we really know, and I would not go to the concept that this is not as effective in people who don't have pes cavus.
Can you talk about part 2 of the trial, which is now getting underway? Patients will be treated at a predetermined 100 milligram daily dose. Why was this dose chosen? And is there any real difference between this dose and the optimal dose, 160 milligrams, identified in part 1?
Yeah. So the study is now beginning to recruit at sites around the world with the upcoming investigators meeting next month. The particular dose chosen for the second part of the study reflects an intermediate dose between the two relatively effective doses in the first part of the study. It's a packaging issue and ability to have patients take an easier dose than either of the other ones.
So on that, there's an extension open-label study will be conducted as part of the MOXIE trial. For how long will it run, and how will it give a fuller sense of this treatment's possibility in the clinic?
So it is planned that there will be an open-label extension. Details to be fully revealed when we reach that time, including bringing people from Part 1 back as part of the plan. It will be helpful in getting long-term safety data so that we have more exposure of people to be sure that it is as safe a drug as it appears to be in its first study. It also may be able to provide what I'll call adjunctive evidence supporting a benefit in individuals as they go back on, though we'll see about that when it occurs.
Is there anything else you'd like to discuss or further clarify?
No, I think we're excited about watching things proceed.